First, I wanted to give you the opportunity to talk about the concept of respiratory health. You and several of your colleagues published a perspective in the American Journal of Respiratory and Critical Care Medicine several years ago, I believe in 2018. In that article, you offer a conceptual model of respiratory health. You point out that respiratory health is often defined as the absence of respiratory disease with no intermediate state of impaired respiratory health, and then go on to compare that to the definition analogous to one in cardiac health and disease. Can you please explain to our listeners the model you are proposing?
Yeah, well, thanks for having me, Al. It's really great to chat with you about this. This is this concept of impaired respiratory health is predicated on the notion that you and I and every other lung doctor from time and eternity has defined disease by physiologic impairment. So we have always used pulmonary function testing as our key definition of COPD, for example, whereby if someone crosses a threshold of abnormal lung function, in that case, the forced expiratory volume in 1 second to the vital capacity ratio being less than 70%, then you have obstructive lung physiology and you have COPD. But that might happen, just take, for example, someone could cross that threshold at age 57. We then behave as if that person had blown into the machine when they were 50, 45, or 40 and did not have lung function below that threshold, that they were normal. But of course they were not normal. They didn't wake up one morning and develop chronic lung disease. It went through a progression across their life course. And by ignoring what we term the intermediate phenotypes of what someone looks like as they transition from ideal respiratory health, as good as they get in their early 20s perhaps, to chronic lung disease, we eliminate the opportunity to intercept the process and actually change the public health. On an individual level, it's really, important to define disease. On a public health level, it's really important to think about these intermediate impairments so we can actually try to intercept. Cardiovascular people have, in fairness, more information than we do in their ability to do this. But when they say in primary care, we should check cholesterol, it's because an elevated LDL cholesterol is an intermediate phenotype of impaired cardiovascular health that is on the pathway towards atherosclerosis and heart attacks. Now, they were afforded through studies like the Framingham Heart Study, started in the 1940s, with a longer time period than we have to figure this stuff out. But that conception of the intermediate phenotypes, high cholesterol, high blood pressure, physical inactivity, those intermediate phenotypes inform disease interception and health promotion such that the burden of heart attacks goes down in society. And we need to think creatively in the respiratory space about how to do that. And that's sort of the fundamental thought behind that framework that we presented in that paper.
Well explained. And in that paper, so you go on to point out two concepts that help explain this model: pulmonary reserve as reflected by peak lung function, and susceptibility as reflected by risks for future accelerated decline in lung health. Can you go on to explain the pulmonary reserve first?
Yeah, so when we say pulmonary reserve, what we really mean is peak respiratory health, if you will. It's the amount of capacity and resilience someone requires sort of through their early life. So some kids are born premature. We know that kids that are born premature are at risk for lower peak lung function in young adulthood. They have less reserve, if you will. We know that children born in houses where there's lots of secondhand smoke, grow up in houses with lots of secondhand smoke or other airborne pollutants, gases, vapors, fumes, are probably susceptible to those fumes in the sense that they acquire less peak respiratory health. That's not necessarily been proven in a bunch of studies. There's a number of studies that I seem to hint at that notion. What about kids who get RSV in childhood? does that lead to a lasting impairment such that they have lower reserve, they have lower peak lung development in young adulthood? So if you have lower peak development in young adulthood, i.e. your starting point is lower than someone who has ideal growth throughout their life course, then you're at a disadvantage. And even if those people don't have an accelerated rate of decline in lung function, even if those people don't smoke cigarettes, even if those people don't work in a factory or a mine or have other exposures with household cleaners or hair chemicals, those folks are perhaps at a disadvantage compared to people who have higher lung function. And what can we think about for those people to enhance their resilience such that they don't experience chronic lung disease in the future based on what happened to them or what they were exposed to in their growth period throughout childhood and young adulthood?